Thank you very much. And I'm glad to be with such a small and intimate audience right now. And as I said to Bob a few minutes ago, I was multitasking and trying to parent my child who seemed to have lost her father, or my husband seems to have lost his daughter. And I realized that before I left, my daughter said, "Do you like going and talking to all these people?" And I said, "Well, yeah, but I also like it when they talk back." And so I'd like to be able to go home and say that everybody participated. And I know there were several other conversations today on asthma and community health workers. I know John and the other people from Boston did one. And I think there was one other session on community health workers and asthma yesterday. Is that right? And I don't know if those people are still here, or any of you, the people who spoke. You did yours yesterday. Right, the Chicago group. Did they speak yet? Yes. But they're not in this room, is that correct? I only know them by phone, so that's why I wanted to. So I'm saying that because I think that many of you are actual community health workers or run your own community health worker training programs, specifically around asthma management. And so please feel free to raise your hand or pipe up. Again, we're such a small group that I think that we can be somewhat informal here. And the other thing I wanted to say is that it's really great to talk about community health workers and the outcomes and what community health workers do. But I don't want to repeat stuff that was already said at the conference in terms of some of the specifics. So I'm going to try to focus on two other things. So I may deviate a little bit from my slides. But one is sort of what are the actual components that need to go into recruiting, training, paying for, and utilizing community health workers, and frankly get buy-in. I mean, I work with a lot of really wonderful community clinicians who feel like they went to med school, they went to nurse practitioner school because they wanted to do this stuff, and they feel a little bit threatened that some of their job responsibilities are being taken away. But I want to framework all of this within something that I know my colleague Anna is talking about right now, and that's the patient-centered medical home. And my talk this morning on diabetes group visits focused a lot more on how group visits fit into the patient-centered medical home. But I think what's important to look at is, as we remember from the plenary session this morning, and the woman who talked about the Affordable Care Act and the state of Colorado, we're really transforming how we deliver health care. And it's not just the doctors and the nurses know and do everything, and who cares, anybody else in the office. But we're really looking at the team approach, whether it's the front desk person, the administrator, the health IT person, the diabetes educator, the asthma educator, the community health worker, are all now considered an essential part of the team. And if we think about how we want to ultimately reduce healthcare disparities in all chronic diseases, including asthma, the doctors and nurses can't do it all alone. And I get worried about the amount of patients we're going to be required to be seeing when all these people get insured, which is really good. I'm happy about that. How much more stressful my job is going to be as a healthcare provider. And so if we can dissipate the work among a team approach, we are in line with some of the goals of a patient-centered medical home, and we are providing care in a way that is bound to be more culturally and linguistically competent, and especially with respect to asthma and public housing, it may address many of the triggers that residents of public housing face inside their homes. So just to start out, I like to think about a specific patient. Actually, one other thing I wanted. Who in the room is actually a community health worker? So about half, a little less than half the audience. So that's helpful to know. I think that we all know the extent that asthma affects people that we work with. I know that a statistic that I pulled up is that 20% of the residents in Boston's public housing have been diagnosed with asthma. Maybe that number is even higher now. And I always think it's interesting to say when somebody has been diagnosed, because there are many people who are undiagnosed because they don't have access to care, or frankly misdiagnosed, both as providers and as consumers of healthcare. We don't like to hear about a chronic disease. So I can't tell you how many times I've seen reactive airway disease. And, it's no secret to healthcare providers, but reactive airway disease and asthma are actually the same code numbers, the same thing. But for a parent who's learning how to take care of a child with asthma, reactive airway disease sounds like, post-viral cough, and may not be associated with a chronic disease, whereas asthma is. Generally across the board, people who live in public housing have 2 to 3 times the national average of diagnosis of diabetes, and poorer people generally have higher rates of chronic diseases, including asthma, and poorer outcomes. And what do I mean by outcomes? Quality of life is decreased. People say they're up at night coughing. They can't go to work because they're coughing. They're spending more time at the hospital. And poorer outcomes may mean more hospitalizations, more hospital utilization. And again, in thinking about how are we going to pay for healthcare reform and what are we getting after in healthcare reform, we're looking at ways to decrease costs. And one of the ways to decrease costs is to keep people out of the emergency room who aren't having true emergencies or who could be prevented from having an asthma emergency. The current prevalence of asthma is about 25 million people. That's about 9% of the population. There were 1.75 million asthma ED visits in 2008. And that just gives you an indication of the utilization of that. And so when I said we'd like to put a face on it, I call this little child Rosita. And she's been diagnosed with reactive airway disease or maybe even asthma. She lives with her mother, Gloria, in low-income housing. She is one of the 14% of people in the United States who have a health literacy level that prevented her and her mother from performing basic tasks. That may mean reading the insert that goes with her inhaler. Her mother had been to an emergency department, an urgent care clinic. Each time she was given different medications. She was confused at how the medications worked. Her mother didn't know. The medications were prescribed that weren't on their health plan, but the person at the Target clinic didn't really understand what the CHIP program was, and so gave her something that she couldn't afford. The mother had to decide, do I buy her new sneakers and she wants to try out for the soccer team at school, or do I buy her this medication? And the child, of course, wanted the new sneakers. You know, meds versus sneakers. You know, most kids would pick a cool pair of sneakers. So she was, both Rosita and her mother had a great deal of confusion about their asthma. About her asthma, and she was taking her medicine incorrectly. And it was this downward spiral where she'd be sick, and she'd miss school, and then she'd get behind in school, and then she'd get frustrated, and then she was trying out for the soccer team, and she had exercise-induced asthma, and she was coughing a lot, and then she got kind of embarrassed about trying to play a team sport and actually have this cost, and she was missing days at school, and then she was getting behind, and then they kind of tagged her as a problem child or a child with ADD because she had missed these days, and her mother missed work, and so on and so forth. So when asthma is poorly managed, the impacts are not just felt among that person, but it's also the community, the school, lost school days, lost work days, and the concern that her mother had about dealing with her being sick all the time. Her mother didn't understand that asthma was a chronic disease. So many of the barriers that she faced, I've touched on. They had health literacy issues. They didn't understand the medication. And she lived in public housing, which was just filled with the common asthma triggers that we'll talk a little bit more about later. So on top of this, Rosita's family did not speak English. Rosita's English was pretty good because she was at school, but it was her mother who was the one who was taking her to all these appointments. And so every time she went, she got a lot of handouts. Somebody told her what to do. Somebody even showed her how to use the inhalers, explained to her where she needed to go, maybe even gave her the paperwork for a patient assistance program to get the inhalers, talked to her about how she needed to get a spacer, and it just went all over her head. And Rosita's mother, like many people who don't speak English well enough, said, and when somebody said, so you understand, right? She said, because she didn't want to say that this was so overwhelming. She was one of 55 million people who speak a language other than English at home. And one of the things that I've seen, which is a little bit of a deviation, but I think it ties into the role of community health workers, is in my 20, 25 years in community health, I've seen a lot of providers who say they speak, for the most part, Spanish, or it could be another target language. But we're so anxious to get providers who speak Spanish. Nobody tests them. Nobody is in the room with them to see if the patients are really understanding. And in fact, Kaiser Permanente in California did this great study where they anonymously called up providers who said they spoke another language besides English. It was not just Spanish, many Asian languages. And they interviewed them over the phone, and they used some assessment tools and found that many of them had the target language at a level where they could talk to the grandmother over Christmas about the Christmas present, or help their parents learn how to facilitate buying a house, but they didn't have the medical jargon down either in one language or the other. They may have gone to med school or gone to their provider training program in this country, and they didn't know the word for gallbladder or the word for inhaler. And so they may have been fluent in a certain way, but in terms of being able to speak medical language, they didn't have that. And it was crushing for some of these people, and they're like, I'm a native Spanish speaker. I grew up with my grandmother who only speaks Spanish, but they didn't actually have the skills to talk to the patients. One of the things they did with this is they interviewed some of the patients. And so I think we need to be sensitive, and this is a whole other topic, one on the importance of trained and certified interpreters. I think we need to be sensitive to the fact that just because a provider says they speak Spanish, they may not have the specific skills that a community health worker who's actually from the community may have in understanding even the street words for the certain language. There was a study done that looked at the relationship between language proficiency and asthma morbidity among inner city asthma patients, and it's probably no surprise to you that people with limited English proficiency had poorer asthma control, higher rates of resource utilization, meaning they went to the clinic, they went to the hospital more often, and a lower quality of life. And so one of the things that we in the provider world have not been able to do is to really address language barriers, and that's something I'll talk about a little bit more with community health workers. So in my job at the Association of Clinicians for the Underserved, this is all tied in with the federal action plan to reduce racial and ethnic asthma disparities. And that's a bunch of governmental like gobbledygook to say that the CDC and HUD and Health and Human Services and the EPA have all been sitting down together to talk about asthma. And one of my favorite lines I heard recently was a great NPR story that they did, again, from a home visiting program in Boston, where they said to treat asthma, treat the home instead of the child. And I always like being at the public housing conferences because there really is a lot of discussion around HUD's role in safe and healthy housing. And having HUD and HHS at the same table to develop this plan was really exciting. And so the components of this plan looks at removing barriers to delivering guidelines-based asthma care. So you go to any clinician, you say, do you know their asthma guidelines? Yeah, I think that National Heart, Lung, and Blood people, they did those guidelines. Do you know what the guidelines say? Well, no, I've seen a copy of the guidelines. They're this thick. And so there are these great guidelines out there, but often providers don't even know what they are. And part of this action plan was to deliver community-based care, which is something that's very hard, again, for healthcare providers to do without the support of the whole team, without integration of community health workers. And then identify those most in need. Well, when I'm in a room with a patient, I don't exactly know what their house looks like indoors. I don't know the level of mold in their bathroom. I may say, have you ever seen cockroaches at home? And I always couch that with, I've seen cockroaches in my home too, so they don't think that they're the problem and I, being the healthcare provider, have a perfect house. We say, like, I've had mold, I have a kid with asthma. I always bring up that it's not just them, but really understanding what goes on in the community and what goes on in the home is something that community health workers have an open window to that providers don't often have. And that's accelerate efforts to prevent the onset of asthma, part of this plan. And so again, talking about disparities in asthma and ways that community health workers can get engaged. We know that people live in poor housing stock. We know that the cost of medication is prohibitive. It's very hard for a patient to say to a provider, you gave me 2 different inhalers, but I only used one because I couldn't afford to buy both of them. I lost one and my health insurance wouldn't cover this one because they said I shouldn't have been done with this one yet. And, all these things, they just say, yes, I'm using my medication as you told me to, because they don't want to say that they're not using it correctly. Having access. It's often very hard to have access to a healthcare provider. It may be easier to call up a clinic and talk to the community health worker and say, gee, I'm having trouble with my using my spacer. Can I walk through this with you? I've touched on literacy, culture, and language. And so these are all ways that community health workers can be involved. And I started out talking about the patient-centered medical home. And to me, one of the things that's really exciting is just like having safe and healthy housing is important, having a healthcare home where a patient feels comfortable walking in and talking about their problems, and that there are resources for somebody like Rosita, where there are people who know the pharmacies, where there's a pharmacist who speaks Spanish, or as I touched on my presentation earlier today, I have a large Ethiopian patient clientele, and I have a pharmacist who speaks Amharic. People who know the community and can bring the community aspects to the health center, an important role of community health workers. There was a discussion a little bit this morning in the plenary about federally qualified health centers are supposed to have 51% of the people on their board as who are patients. And I know in my clinic, it's the community health workers that have been able to identify the patients. And patient-centered medical care is centered around the patient. And so what are the resources that we can provide in terms of care coordination, patient tracking, medication management? Again, it's way too much then that the providers can understand. So that brings us to what is a community health worker. And at this point, I feel like I'm speaking to community health workers who could probably say it better than I could say it. But the American Public Health Association defines community health workers as a trusted and trained member of, or somebody who deeply understands the community and is a liaison between the healthcare, the social services, and the community. A community health worker can build capacity through outreach, community education, in other words, a whole group education, informal education, counseling, social support, and advocacy. This is a group of community health workers with which I've worked called Salud es Vida, Health is Life, and they are part of the county health system where I am. And I bring that up because I think it's important to be aware that just like Rosita's mother went to a community health clinic and the school nurse and a target clinic in an emergency department, and there were some things that happened in all those places and nobody was really pulling that all together. There may be numerous community health worker or promotora de salud or peer educator groups. So these community health workers specifically go into the schools and do education in the schools with kids and parents who have missed school days, kids who have missed school days due to asthma and their parents. So they're not integrated into the community health center. And I bring that up because I think it's important to realize that there may be numerous community health worker groups working together. Some of the local emergency departments, after kids have been seen for an asthma visit, then send a community health worker out to the home. So I think one of the weak links that we need to remember is that there may be improved access to information, but there may be conflicting information with this exciting developing community health worker role. And so we really need to find out who, if there is a patient-centered medical home, that they are coordinating with other community health workers that may be working with the patient. And you can just believe me and say that, their studies show that community health workers really have improved outcomes. But I always like to bring it back to the evidence. And in preparing for today, I pulled an article called Community Health Workers and Environmental Interventions for Children with Asthma, a systematic review. And these were people out of University of Washington, and the people in Seattle, Cook County have done amazing work with community health workers. And they went and looked at the outcomes of people who had interventions with community health workers. And they found increased trigger-related knowledge, improved trigger reduction in the home, improved asthma health outcomes, decrease of symptoms, decrease in limitations due to activities because of asthma, decreased use of the emergency department, many other positive health outcomes, including decreased limitations in terms of physical activities. And I can talk more specifically about some of these studies. But I just wanted to bring up some successful models that I've had the opportunity to know about. WIN for Asthma just won the EPA Leadership Award, which was a collaborative process which involved doing education in the daycare centers, in the schools, in the clinics. Once families were enrolled in this, they had bilingual community health workers do family-focused education. In the community health world, usually it's one parent or caregiver who brings a child in, and we know that healthcare happens more outside of a clinic, and so engaging the whole family was something the community health workers were going to be able to do. And they went door to door, and they did some asthma trigger management at home. And over a 3-year period, they decreased the number of asthma-related emergency departments by more than 50%. A community health worker project in Rhode Island found that by using community health workers, they saved on the average of $2,000 per patient just by using community health workers. The group on the left are a new group of community health workers that were trained in Washington, D.C., and I know the studies out of Boston are also really encouraging. And so back to this idea of, which was written up a little bit in the Healthy Homes document from HUD, is to treat the asthma, we have to treat the home. And as a clinician, I can say, you need to get rid of cockroaches, you need to get rid of mold, too many stuffed animals in the house, check, 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 check. I've checked it all off on my electronic health record. But we really don't understand in how to engage in that patient education. And when I talked about that there are these really good guidelines from the National Heart, Lung, and Blood Institute that talk about asthma management, they talk about partnering with patients, the appropriate use of steroid inhalers, trigger reduction in the home, but and the use of other medications. And as clinicians, we learn about inhalers and medications and flu shots and how to rule out pneumonia and how to rule out if it's viral or bacterial. We don't really learn about patient engagement. And so this, again, is something else where community health workers can jump in. The question is, if you have a group of people and you want to bring them in to be community health workers, how are you going to train them? There are many training curriculums out there, but there are also many different models that are used. Some places just train people specifically on asthma, so that's what they do, asthma outreach. Some places talk about the community health worker is more of a generalist, and you sort of add things. Let's start with bringing you up to speed on some diabetes education, and when you get done with that, we'll move to asthma. The group that I showed from the county where I live, they were specifically around asthma and specifically working in the schools. Unfortunately, some of the training tends to be based on where you get the funding as opposed to what your community needs are. Obviously, it would be good if those two could be mixed together. One of the things that I think a lot about with community health workers is this real openness to more creative training approaches. There's a woman I know in my community. She's about so high, Hispanic grandmother. She always wears her little apron even when she's not cooking, and she goes out to the soccer field and she talks to the young men who are playing soccer. And in her little apron pocket, she fills it up with condoms. And during the soccer break, she goes up to the guys and she starts handing out condoms, and they start throwing them around. And then she starts lecturing on them how much diapers cost if they get somebody pregnant, what their responsibilities if they get somebody pregnant. She has in her head all these statistics on Latinos and HIV, STDs. She describes in detail what happens to them if they get an STD. And she is probably in her early 70s, like I said, tiny little woman, and she has taken on her role to be a community health worker and do asthma prevention in the Latino community because she lost a son to HIV. I'm sorry, I said asthma. I meant HIV education. And to me, she's the example of has a very creative approach to, people don't suspect her. They all call her abuelita, little grandmother, even if she's not their grandmother. And, they're all taken aback when she starts throwing condoms out of her apron pocket. And so that's the kind of really creative education that I think is key, using puppetry. And I know there was a session here, I think it was this morning, on some theater stuff. I think folks from North American Management did it, and using more theater in education. And my start to healthcare was working in Latin America and doing a lot of creative education. And when we talk about health literacy, sometimes as simple as something may be written, if you can't read and it's written in fourth grade language, but you can't read, it still doesn't get you anywhere. And so much about asthma is hands-on, do, and it's understanding. People are much more likely to use their medications if they have more of an idea to see how they work, to see what asthma is all about. So in terms of community health workers and getting involved in asthma education, as I mentioned, there's some great materials in Spanish. There's some great pictures that I've seen people use. The thing on the left was a little puppet kind of thing that people made in a community health center with patients, where they sat around and they said they asked people to do drawings and cut out, felt. If you can go to an art store and a little thing of felt is like 29 cents. We're not talking about big costs here. And they used clothespins and made these little figures so that the people they were teaching about asthma could then go home and teach their families. And the alternative to that is an asthma education brochure that I picked up that talked about, and in my PowerPoints, I believe you shouldn't have too many words, so I'm intentionally violating my own rule about PowerPoints to prove a point here. But the number of puffs contained in your meter dose inhaler, where is it? Oh, for example, if your MDI is 200 puffs, you use a total of 4 puffs per day, and divide 200 by 4, in this case, your MDI will last 50 days. To me, that sounds like one of the math problems my kids have on the standardized tests, and I'm not sure I would understand how to do that. Plus, you got words in there like the propellant with drug suspension and aerosol, and, is this really what people need to know? Whoops. There we go. As opposed to plain language. To understand asthma, first we need to know something about breathing. The airways that move air through our lungs looks like an upside-down tree. So one thing I saw a community health worker do once is bring in a stalk of broccoli and say, turn it upside down and say, this looks like the inside of your lungs. Gee, are our lungs green? No, your lungs aren't green. Your lungs should be pink. But if you smoke, your lungs may be brown. But to be healthy, you want your lungs to be pink. And then start engaging in some of these words. Just because somebody may have low health literacy doesn't mean they can't use words, so they're interspersing windpipe with trachea and air tubes with bronchi and so on. Use of pictures, a normal airway versus one, why does my chest get so tight? Why can't I breathe? Well, the airway is narrowed. You know what it's like when you have a hose and somebody steps on the hose and the water can't come out. There should be, this much space for your air. And when it's made smaller because the muscles are very tight, it's a lot harder to breathe. Something that I loved that I saw one time was a community health worker gave everybody a rubber band and asked them to put the rubber band around their little finger and to twist it and twist it and twist it. And then they said, well, how does that feel? And says, oh, it feels really tight. It hurts, and my finger's turning purple. Well, your lungs have little bands that wrap around the part of your airway, and they get very tight when you have asthma. And so your lungs inside, when you can't get the air through, it feels like your finger's not getting enough blood, which has oxygen, and your lungs aren't getting enough of the air that has oxygen. And so everybody, can relate to putting a little thing around their finger. Another thing that I thought was brilliant that I saw from a community health worker was a family that could not afford the spacer. They were recent arrivals, were not eligible for really one of these horrible situations. Couldn't get on the state program because they actually made too much money, but didn't have access to health insurance and were undocumented, and so they couldn't get into one of the health insurance programs that takes care of people in the county. And the long and short of it is they needed a spacer, and the community health worker was sitting around a room and picked up a water bottle just like that and said, well, maybe we can make a spacer. And in fact, they cut a little hole out of the bottom and put the inhaler in the bottom, and the mouthpiece was the mouthpiece, and they basically fabricated a spacer for a child who needed one who couldn't afford it. Another area that I think from the clinical point of view takes a lot of time, that again, the community health worker can spend time either in a group or individually or in the home going over the medications. And I had a patient who once said, I said, which inhaler are you using? The pink one. I said, okay, I'm not really sure what the pink one is. She said, well, it's not one of the ones you prescribed me. You prescribed me a blue one, but I like pink better, so I'm using my friend's. It's very hard to know what patients are on. Sometimes if you show them a picture like this, they can say, yes, it's this one. trying to remember, I'm pretty sure it's in England, it may be in Australia, but even though there are different drug companies, they all have to make them look exactly the same, so you don't get this confusion over how they look. And so, one thing that may be pink one month is blue the next month. I know that my kid who's on a steroid inhaler and a short-acting beta agonist, both of them are red, so you can't say it's the red one because they're both red. So really kind of figuring out which medications that the patient is on and updating the electronic health record, that's an important role. Group asthma visits. This morning I talked for a long time about group diabetes visits, and one of the questions was, what other groups lend themselves to group visits? I think that asthma, like diabetes, where there's so much mechanical stuff with insulin, lends itself to group diabetes visits. And again, the return on investment is phenomenal. In a randomized control trial that looked at the return on investment when community health workers did group education visits, they found that for every $186 spent, they saved over $6,000 per patient in direct and indirect expenditures. And I bring this up because right now our health system is not set up in a way that reimburses anybody, for the most part, other than a licensed clinician. And I think that's one of the barriers to community health workers right now. Who's going to pay you? And how are we going to be able to provide this unless there is some kind of reimbursement? I know in some places you can bill for community health workers. I'm pretty sure Rhode Island is one of them. I don't know about Massachusetts. That may be one of the other ones. And I think in Washington State. But people love to get together in groups and talk about their problems. So that's a key area. Again, I could say this with every slide, but it's not enough to treat the child. You have to treat the home. And I don't think we really know the conditions people live in unless you're in the home. And I've done home visits where I've seen kids hanging out windows where there's no screens on the window and it's a health hazard, and called the landlord and got screens. I've seen them say nobody smokes in the home, and you walk in and the house is filled with smoke because they don't want to tell you somebody smokes at home. Home visits are probably the best way to provide asthma education, but they're not going to pay a nurse practitioner or physician for the most part to go into the home, where community health workers may know the neighborhood, know people in the community, and be much more welcome into the home. So there are many projects where community health workers can go in and look at specific asthma trigger reduction. And people always say, well, what are the tools? What can be used? There are numerous tools out there, but one of my favorites for home visits is the EPA Home Checklist, because I would not remember all the things to bring up, but if it's written on paper, something like this can be taken into the home by a community health worker, checked off. This is just talks about the pets and the consumer products in the heating and cooling system, but it's several pages, and it goes through all of the most prominent asthma triggers, and then says what they need to do, and then can figure out how to intervene. So does the heating and cooling system use filters? I don't know. And then the community health worker might say, need to check with landlord about filters. Call up the landlord. I'm calling from such and such a clinic. I'm the community health worker. I'm working with the Smith family. Johnny's been in and out of the hospital with asthma. We know that there are some triggers in the home. We need to find out if you're replacing the filters quarterly, as indicated by HUD or EPA or whoever decides when the filters, or the company that makes them. And picking up the phone and calling the landlord. One, they may not know. Two, they may be less threatened by having a community health worker call up than having a lawyer call them up. And these are things that patients may not be able to do for themselves to advocate for some of the bigger changes in the home. One of the things that's important about some kind of checklist like this is having making sure that information gets integrated into the health record, so either photocopied and put in a paper record, scanned into electronic health record. Or one of the things that we've been doing with our EPA funding at the Association of Clinicians for the Underserved is embedding this in the electronic health record, and it doesn't need to be filled out by a clinician, so an asthma home visitor can check all this off, and it's actually in the electronic health record. And it's important because, jumping back to the National Heart, Lung, and Blood Institute guidelines, it says we're supposed to engage with patients on asthma trigger reduction, and when somebody comes in very sick with asthma or with an acute respiratory problem and we're worried, do we need to send to the emergency room? Can I give them a nebulizer treatment here? What's their pulse ox, meaning how much oxygen is in their blood? Or, are they okay? We don't always do the trigger management, and it should be done when somebody is healthy, not when they're sick. And we need to make sure that that's documented. And so this is a good way to do it. I don't want to talk a whole lot about asthma trigger management. I'm going to touch on it a little bit because I think probably most of you all know about it. But I do want to say that as healthcare providers, we, and I include myself in this, suck at it because I'm too busy in the room ordering the flu shot, looking at their childhood immunizations, and it's very easy for me to say you got to get rid of dust mites. Well, who's ever seen a dust mite with a naked eye? Nobody. And it takes time to engage in that kind of asthma trigger management, even though all the studies show that there are the results of home-based environmental trigger management really help kids with asthma. John? Yeah. That's an excellent, excellent, excellent question. So in the old days, which were not so long ago, to test for certain triggers, you had to send, usually you had to send, I'm going to say a child, it could be an adult, to a specialist. And they did allergy testing by, if anybody's ever had a TB test where they put a little bit of a substance under your forearm, and if you haven't and you work in public housing, you probably should. And you want to see if you react to it, if your body has antibodies to it, which will cause it to get a little inflamed. Well, the allergist would do the same thing, and they would do everything from grass and different kind of grasses and molds and pollens and dander, and it was some kind of, it's a little bit hocus pocus to me, but it was some kind of serum that they'd put in. Usually they do it on the back, and they put a little bit of stuff in, and then they look and see what you react to. And that was how they tested for it. And one of the challenges with low-income people for that was that it was hard to get people in to see a specialist. Specialists don't like to see people who are uninsured or have Medicaid, where our CHIP program pays for primary care, but it doesn't pay for specialists. Certainly the specialists are usually not up to board with where I think they should be with cultural and linguistic competence. They're out in the suburbs. People can't get out there. So it wasn't happening. Now, in the last couple of years, there's been really good blood tests that have been done. And the thing that I think is really good is that it's regional. So when I order that blood test, it's region 3, where I live in the mid-Atlantic, and so it looks at grasses and plants and mold and dust that's particular to that region. Some stuff may be universal, like pet dander, but a lot of the plant-based stuff is not, is region-specific. And so then the blood test comes back, and it'll tell you, and it also deals with peanuts and milk and other things, soy, how sensitive you are. So, and some things may be off the charts. And so, yes, you can do simple blood tests. And I believe most insurance plans will pay for that. And that's really key, because why bother doing dust mite remediation in the house, which is a lot of work, if, hey, your trigger is the dog and it's not the dust mites. However, for many kids who have severe asthma, they are, and often you've probably seen this directly, they have a lot of skin problems like eczema. They're just highly sensitive. They have high levels of allergies, and many of them may also have a peanut allergy or a soy allergy. So kids who have allergies tend to have many of them, but if you can figure out that, hey, there's one that they don't have, why bother doing that? So just quickly, in terms of some of the work around trigger management, I've seen some interesting documents that talk about washing bedding in water that's greater than 140 degrees Fahrenheit. Well, if you're low income and you're carrying all your laundry, down 4 flights of steps and then walking 2 blocks to the laundromat, and it's 90 degrees, you're not going to say to the laundromat owner, hey, what temperature is your water at? Oh, it's 138 degrees. Thank you very much. I'll take my laundry another 6 blocks away. It's not going to happen. At the same time, we're also really interested in doing anticipatory guidance for children around hand washing and using hot water to wash their hands after they go to the bathroom. So on the one hand, we're saying, don't make your water too hot because you don't want your kid to burn themselves. On the other hand, make your water hot because you want to wash your clothes. We're giving a lot of mixed messages. What I like to say, and can be discussed with the community health worker, is wash your bedding frequently. Limit fluffy objects. Dust mites are, they're like the rest of us. They like comfy things, something that's soft. The more stuffed animals you have, the more dust mites you're going to have. Keep the dust mites out of the bed by keeping the stuffed animals out of the bed. Really focusing on a safe sleeping space. And I think that that's a really important point because a lot of folks double up in apartments, are temporarily staying with other people, and the child may not have a bedroom. The child may be sleeping on the same couch that the sibling ate cookies on, and therefore there may be cockroaches looking for the cookies, and the dog jumped up on the couch, and the father smoked a cigarette on the couch. The child is going to sleep on a bed or on a couch that's just filled with triggers. And in a clinical setting, you might say make a safe sleeping place or tell me about where the child sleeps. But a lot of people don't want to admit that the child doesn't have their own bed or their own bedroom. It's by going into the home, it's something that you can see. We could do a whole session on, and I think John and his people in Boston have done this, but specifically on integrated pest management, but which means using the least amount of the least toxic material in the smallest part of the home. And the thing that I think is really important about this is that I see people who buy these cans of Raid and they spray it around the room like, it's confetti at New Year's, and there may be an infant in the home or a pregnant mother in the home, and a lot of the products out there may have high toxicity. In a home visit I did once with a community health worker, they said that they were using a product called Chinese chalk. And I said, well, what is it? And they said, I don't know, the directions are in Chinese. And it was a big thing of chalk, and it looked like it was white. And I thought, well, maybe it's some kind of compressed boric acid, which is considered to be very, very low toxicity, also very inexpensive, and also very effective against cockroaches. So I took the Chinese chalk to a friend of mine who is in med school, and before she went to med school, she had an amazing job working in China with the CDC and learned Chinese. And I asked her to say what it was, and it turned out to be something highly toxic, and it wasn't boric acid. And the family had bought this at the little bodega, the little Latino store. And so really looking at what products people are using and how to safely use products, and also encouraging people to eat in one part of the house. So if you do need to use something, you can just use it in that part of the house. Go ahead. Yeah. Oh, yeah, that's an excellent question. So for pests, it's usually the cockroach. It's actually, people have allergies to the body parts, and little pieces come off, little pieces, I don't know if they have antennas, but little pieces like little legs and little antennas. With rodents, it's the hair, so they shed, like dogs and cats shed. The skin flakes, our skin flakes all the time, when we sleep and when we're walking around. But rodents, their skin flakes off too. The saliva and the urine that dry, they flake off. So all those things, so even if you're actually not seeing the cockroach, or you're actually not seeing the mouse, there are mice because there's little mice turds, but you're not seeing the saliva, you're not seeing the little pieces of cockroach leg that came off. Cockroaches, they're kind of gross. They eat each other, so they might drop a little piece of somebody along the way. And all of those things are what are triggers. And what that means is our body kind of like freaks out, and it causes an allergic reaction. Some allergic reactions are what you get. You get a big bee sting, and it gets a little swollen, or One of my daughter's friends used the sunscreen the other day and got an allergic reaction, broke out in hives. That's your body, that's one kind of allergic reaction. Another kind, specifically with relationship to asthma, means you're going to get more mucus inside your lungs, and your airways are going to narrow because they're going to get filled with mucus, and those bands that go around are going to get tighter, and it's just your body's way of saying we don't like each other. Why does it happen to you and it doesn't happen to me in the home, or to your brother and not to my brother in home? That's really the big question. There's been a lot of really interesting work done on kids who are spend more time on farms and outdoors and maybe exposed very early to certain things and develop certain kind of resistance. And I think that's sort of the next level, and we're looking at that with all this genetic sequencing, why some kids are more susceptible than others. What we do know is that it may be the amount of triggers, and low-income housing has a lot of triggers in it, and so they're exposed to a lot at a younger age. The other thing is that it's good that we're able to keep premature babies alive, whereas 20 years ago babies would die from respiratory infections or lungs that weren't fully developed. Now we have all sorts of interventions to keep kids that are born prematurely alive, but the consequence of that is more lung disease and more, other respiratory problems. And we know that people who live in public housing have higher rates of premature birth. They may be exposed to smoking. I'll talk a little bit more about smoking in a minute. And so their lungs may be compromised in utero or at birth, and so that may make them more susceptible to asthma. So why is it that some kids get it and some kids don't? The many disparities that exist in public housing may make it worse. Mm-hmm. Mm-hmm. Well, this is not a scientific answer, but I live behind an apartment building, and I know there are rats there. There's a couple of restaurants near there, and I know there are rats, and I've had mice in my house, and so I haven't hopefully I haven't a rat in my house, but I don't know the answer.
I don't know what you found on scientific. I mean, in general, mice are a lot more comfortable at a house, a lot more comfortable inside the home, living near people. The rat is really outside in the burrow. I mean, this is their natural habitat. Rat will come into the house and eat the problem couldn't get back out. So I think it's sort of old conventional wisdom. There's probably some truth to it, but
just a couple other things that the community health work can be really effective at is any of these things: rats, mice, cockroaches. They're like the dust mites. They want to sleep on the stuffed animal because it's soft and cozy. These guys like food. That's why they're in our house. And so I had a family where the mother felt like she needed to leave the dinner out for the husband. She went to work cleaning office buildings before he came home, and they had a huge cockroach problem. And I said, you can't leave the dinner out for your husband. I mean, that's really gross. There's going to be cockroaches in your house on his food. But she said, no, I have to leave the dinner out. He won't let me work unless I cook him dinner. And we really had to talk about cultural expectations and norms around women and cooking, and get the husband to see that leaving the food out was, giving a, all-you-can-eat buffet to the cockroaches in the house, and that there were ways that you could cover up the food and do other things, like, wipe down the inside of the shower, and with respect to, I think is my next one, mold. Other creative ways I've seen to get rid of mold, certainly using exhaust fans, and in the area of the country I live where it's really humid, using air conditioning when possible, making sure the showers are wiped down, and actually showing somebody where how to wipe down the inside of the shower. There was a question that came up once at a meeting I was had with the EPA, and they have somebody on staff who is like a moldologist. She's got a more official name, but that's essentially what she is. And I said, people are going to ask about how you clean mold. What's the product? And she said elbow grease. The most important thing is a stiff brush. When you see it, get it when it's when it's just starting so it doesn't grow and grow, and wiping it away. She said, you know, vinegar is fine, bleach is fine, but not together. Bleach may be a trigger, but it's really scrubbing it with hot water. But looking at the kind of bath mats they have, is it a bath mat that can be washed every week? Are they washing it every week? Leaving lights on in parts of the house. Mold likes dark, warm, moist areas. You can get rid of the moisture, get rid of the darkness, leaving a light on in a closet. So that's another area. Pet dander is a little bit tricky. I think if I'm correct, you guys can help me here. In public housing, you're allowed to have pets if they're of a certain size. They have to be small enough. People, full disclosure, I'm not a pet person. It's not me. But people love their birds. They love their dogs. And for a lot of people who are living with chronic disease, who, I mean, I just love it when I see the apartment building I mentioned behind my house is low income, subsidized senior citizen living, and a lot of people are old and in wheelchairs, and they take their dogs out for their walk in their wheelchair. And I think it is the cutest thing, and I appreciate how emotionally how much pets can do for people. But really trying to encourage people to let the dogs outside as much as possible, create safe sleeping spaces, which again is really hard, especially if you have a small pet that doesn't need to go out very much, doesn't need to be walked very much. Cats are more of a problem than dogs. And also, something to remember is that people can bring home cat dander. It's very sticky. And so even if you don't have a pet in your home, if you have a pet in school, it can be brought home. And then, you know, I think a huge one that fortunately HUD has really taken on full steam ahead in public housing is the issue of tobacco smoke. And it's really encouraging to me, do I have this in here? Yes. The federal policy where they've encouraged public housing authorities to implement non-smoking policies indoors, which is key not just to asthma, to many other issues, including the fact that, frankly, for the building owners, it's cheaper to buy insurance if it's a no smoking unit. Well, I think last time I put this together, I said 112 public housing authorities have opted for non-smoking. That number is increasing. Wow, because I checked this not so long ago, and I think that number may be, sometimes it's state and sometimes it's citywide. So that there may be, you know, if it's the state of Massachusetts and the city of Boston, then it's so. Anyways, but I think that this is a really, it's really important. And I had somebody asked me once, well, where does medical marijuana fall into this? And I think it's still out. People have asked a lot about e-cigarettes. There's a really fascinating thing that went on if anybody's ever been in D.C., they're pretty bad about you can't drink even water on the metro. You can't chew gum on the metro. A 15-year-old got like busted for eating French fries and she was 15. I mean, poor thing. But there's been some discussion now whether you can have electronic cigarettes on the metro, which I think is showing poor behavior. And we really don't know what they consist of. But I believe that they are allowed in public housing. Is that correct? No.
Our building
Passage. And where are you located? Okay, so you're local. I think one of the really challenging things as a healthcare provider is we all know that smoking is bad. You know, I could list 100 ways to treat diabetes and to help make sure your diabetes is well controlled. Your medications for asthma, I can talk about 100 things. Smoking is talking about smoking cessation is very hard because it is one of the most highly addictive substances. And I feel like there's a real lack of training. And when I say healthcare providers, I mean everybody, community health workers, doctors, everybody. There's a real lack of training and materials out there. And so we were fortunate enough to get some funding from Pfizer, which is always a little controversial because guess what? They make Chantix, which is a smoking cessation drug. But they dumped a bunch of money into our website to come up with some resources on smoking cessation where we were able to look at special populations, including homeless, including public housing, lesbian, gay, transgender, bisexual, I can't remember, Native Americans, to look at some tools and some patient information on special populations. Because I think that one of the ways that a community health worker can really be engaged is that sort of like the Alcoholics Anonymous, where you have a buddy system. People refrain from smoking longer when they have somebody checking in on them, even if it's just a phone call, giving them positive feedback. And there's a lot of work in the smoking cessation world around motivational interviewing and meeting somebody where they're at, and positive reinforcement. And that's an important role that the community health worker can play and really encourage them around smoking cessation. So I just want to mention that there may be some other triggers that may be hobby related. It may be beauty related, like nail polish. It may be culturally related and religiously related, like votive candles and incense. So those are other things to think about. Moving away from specific trigger reduction, one of the areas where I found that community health workers can play a key role is understanding the asthma action plan. And the National Heart, Lung, and Blood Guidelines say everybody should have an asthma action plan. So there's two parts to this. One is that the clinicians either don't do it or don't know how to do it or forget to do it. And so by putting that in the minds of the patient when they go in, saying, I'd like an asthma action plan, or I learned from the community health worker that I should have an asthma action plan, and there should be one at school, and there should be one at the grandmother's house, and there should be one at the daycare. Oh, yeah, you're right. I'll get on that asthma action plan right away. Ideally, this is something we're looking at. This should be embedded into the electronic health record so that it can be printed out very easily. But it can go two ways. It can come from the patient asking for it in a clinic setting, or it can come from the clinic and then reinforced by the community health worker. And I gave a similar little spiel this morning on diabetes, but one of the things that's fascinating to me is this concept of the stoplight is something that is very understandable. You know, green is go, yellow, be cautious, and red, you're in trouble. And if we break down what to do in terms of asthma in those steps, it really improves asthma management. And we have a page on our website that has a bunch of examples of different asthma action plans in a variety of languages. But the community health work can really work with people on what is an asthma action plan, update the asthma action plan, make sure they have a copy on the refrigerator, review the asthma action plan as part of, and communicate between the different providers or the different places where the child spends time. I mentioned that when people come into a clinic, they're often there with asthma, they're often there for an acute exacerbation of asthma. Nobody says, oh, gee, I just want to go have my asthma tune-up today. I'm feeling fine. People don't come in when they're feeling okay with their asthma, and that's something else that the community health worker can encourage people to do, to come in for planned follow-up care, to look at their medication utilization, review how they're using their inhalers. Are they due for their flu shot? Can they really need to come in twice a year? We're so good at taking our cars in to get our oil changed, but we're not always good about taking our bodies in for the tune-up. So come in when you're healthy so that we can keep you healthy. As a child grows, the medications may need to be changed. They're going off to camp. They're going back to El Salvador for a couple months. They may need, extra medications. And so bringing them in before a problem occurs is really key. And the community health workers can encourage people to do this. I'm encouraged by the increase of community health workers, and that there are 14 CMS Innovations grants that are using community health workers. And the more we can prove that there are improved outcomes with community health workers, the more we'll be able to get reimbursement for them. And and I keep mentioning Boston because friends are here from Boston, but also they've done some incredible work, as has Seattle and Rhode Island, Vermont. There's a whole New England coalition that got, as part of the New England Asthma Innovations Collaborative, got a grant, a $4.1 million federal grant from CMS that's looking at use of community health workers. And I've talked a lot about how encouraging this is and how I think it's great. I also have some concerns and some reservations that I think we need to be aware of. And that is that there are these great curriculums. Sometimes they're online. Sometimes they're in classes. But we need to think that we may be creating a new profession, whereas the community health worker really was born out of people who are from the community, who could teach in the community, like that grandmother I talked about on the soccer field. And we are being asked to formalize it so we could show outcomes, so we can get reimbursement. And some of the concerns I have about that, I know at my clinic, the people we've been able to hire who have the computer skills and the English skills are often not. They're great people, they're young people, they're inspired, but they often aren't really aware of some of the issues in the community as much as some other people who may be these great community health workers but don't speak English or don't have computer skills or maybe don't have immigration papers in order to be able to be hired. So some places are looking to professionalize the community health worker. In my own mind, I question, is there a little bit of a contradiction? You know, we have professional diabetes educators or asthma educators or nurses or medical assistants. Are we creating another profession that's going to have a lot of hoops to go through and may alienate some people who may not have the finances to be able to get the training? However, several states do require certification for community health workers, and you can see that there. But then again, to get reimbursement, we may need to have the certification. So I find that a little bit of a contradiction. I think in Massachusetts, community health workers can be reimbursed, and sometimes it's funder specific. So if the Medicaid managed care plans are funding it, they are willing to fund. They're willing to fund community health workers. Again, we heard this morning about the exciting things that are going on in this country with the Affordable Care Act, and there is a provision in the Affordable Care Act that talks about home visits, and home visits are part of accountable care organizations. And again, they're looking to evaluate the outcomes of community health workers and standardizing training. The training you may have in one state may be different than a training in another state. As a nurse practitioner, it's not that hard as long as I pay my money and didn't do anything wrong. I can go to any state and get a nurse practitioner license. That's not true of community health workers. We want to make sure that we're training people and certifying them in a way that if life makes it so they move, or you live in an area where I live, where people work in Maryland, Virginia, and the District of Columbia, that there's reciprocity with the training, so that it's not if you get a job but you can't do it because you're not certified in that state. So I think it's something we need to look at. And then we need to look at what's the best way to evaluate people. And this is really challenging because you can take a test to get your certification, but we really want to look at your outcomes. Asthma does not lend itself as well to outcomes as my other favorite disease, which is diabetes, where you can do a lot of lab tests and see how their diabetes is controlled. Certainly we can do interviews with the patients about their how many missed school days. There's something called the asthma control test that looks at the frequency and severity of symptoms, and those are all great things, but is that really looking at the intervention that the community health worker did or not? We don't know. And so I think what we still need to develop is how to evaluate community health workers. I think one way that's promising, but it's also a little bit subjective, is to have some kind of supervisor shadow them when you go out on home visits, or you do group educations, or you engage with the patient with some kind of checklist, do some role plays as part of the evaluation. So if you're a community health worker and you're going in the home, you need to kind of evaluate the difference between somebody whose asthma has kind of been uncontrolled and they're a little bit uncomfortable versus somebody who needs to go to a hospital immediately. And that's not necessarily what community health workers are trained to do, but that may fall into their role. So when do they coordinate with, if it's the nurse who's supervising them, or the physician assistant, or the nurse practitioner? Those are things we have to look at. What are the outcomes with patients? What about patient satisfaction? Because I think we do need to figure out how to evaluate to prove that this works, and we need to encourage more investment in community health workers. Again, the Boston people are really in the forefront, but 2 years ago in September, Deval Patrick, the governor of Massachusetts, signed a law to establish a board of certification of community health workers and to get some financing for licensing. And that's hopefully we'll see more of that. And then I see the community health worker as really just one piece in the team approach. And not one person can do it alone. Asthma cannot be cured within the four walls of the apartment building or the four walls of the exam room. It really needs to be a bigger approach with medical legal partnerships and asthma coalitions and school-based health centers and the school nurse and the local retailers who are willing to give mattress covers at a low income cost in case the bed, in case dust mites is the problem. And I think community health workers fit in really well with that because they can kind of be, there's some analogy this morning to yarn and tying knots, but they can kind of be the piece that really pulls everybody together. And as they talk to the patient, understand the school nurse is doing something, and there was a community health fair where they did something, and really understand what all the pieces are and feed those pieces back to the patient-centered medical home where the provider is providing the medications and hopefully teaching them how to use the right medications. And I think I forgot to touch on this, but because of the confusion over medications, really being involved in understanding with the chronicity of asthma, it doesn't go away, but it can be controlled. The importance of this steroid inhaler, and that's often a cultural concern of many patients that, oh my God, my kid can't be on steroids, they won't grow, or he won't be able to play soccer, they'll kick him off the soccer team because you're not supposed to be an athlete and use steroids. And the backbone of asthma management is use of steroids even when you're healthy to keep you healthy. And that's a huge piece that gets missed in asthma management. And again, the community health workers can fill that piece in. So I'm just going to leave you here with this, just with my contact information. And I'm glad a couple of people spoke up. But any comments or experiences that you guys have had with community health workers, I'd love to hear them.